Speaks here about once a year and always brings us up to date on issues revolving around the metabolic syndrome, about which he's a world's expert.
Actually, I'm going to skip around. My own bias is that the metabolic syndrome has already peaked. I'll tell, which isn't so bad after all, you know.
No, it's coming, it's gone.
Well, no, it's not gone yet.
You mean is it peaking? It looks peaking.
It's certainly
it's going away of Syndrome X and all those other.
But I think what I'll do is I'll skip some of the stuff I think I've talked about before, and focus a little bit about definitions, which I won't show slides for. And I'm going to end by talking a little bit about non-alcoholic fatty liver disease and some of our work from IRIS, which is new. We have a couple of papers that have either just been published in Diabetes or in press in this area. Of interest is, you know, we've done stuff cross-sectionally, prospectively. You don't have LFTs in SALSA, do you, Mike?
I remember.
They may have measured it when they went to see the when they were admitted to the VA. I don't know if that's.
Well, if we have SMA 12,
there's actually nothing on this in elderly patients. So that's actually a deficiency. So I'm going to start with stuff we published a good many years ago, sort of as a reference in terms of talking about one of the issues with the metabolic syndrome is how great is the excess risk of cardiovascular disease. So this is a paper we published 7 or 8 years ago, which looked at diabetes and prior MI stratified for future CHD risk over 7 years from a Finnish population. And this data was used to support the concept of similar treatment in diabetic and non-diabetic subjects. And it's this comparison. It's diabetics without a prior MI, non-diabetics with an MI. A couple of caveats about how this was done. Does it apply to the elderly and so on? So one is, this was done in a middle-aged population. There were 45 to 64 at baseline. It was basically a population-based case control study, which then was followed forward. So all of the diabetics who were registered to health authorities were in 2 different counties in Finland. So a little bit over 1,000 subjects. They had an average duration of diabetes of 8 years. They had an average fasting glucose, and this data was collected from 82 to 84 initially, and that'll actually be important for one aspect of this. And then there was about 1,400 non-diabetics. They did glucose challenges, so those individuals who were diabetic discovered in glucose challenges were then included. with the diabetics who were previously identified. So it was overwhelmingly previously diabetic middle-aged subjects. This data is for 7 years. I've seen in a review data which is over 18 years, which in this population looks very, very similar. Now, so let's ask a couple questions. A lot of studies have replicated, some studies have not replicated. What are the characteristics of the studies that replicate and don't replicate? This particular paper is based on average risk of CHD and diabetes. It doesn't actually say anything about whether all diabetics, which is the way some people interpret it, and that of course is absurd. All people with CHD don't have the same risk. Stable angina has a far lower risk than acute coronary syndrome. Second issue was some of the studies which came out afterwards said that when they screened patients for diabetes, they were at lower risk, which actually isn't much of a surprise. We know a duration of diabetes is related. We know that cigarette smoking and cholesterol and hypertension are risk factors. I'll show data a little bit later that diabetes interacts with the metabolic syndrome, particularly in women, and increasing the risk. What about elderly subjects? If you look at Framingham data, and if you break the offspring study into two cohorts, there's one group of under 65 and there's one group of over 65. The relative risk for diabetes for CHD is lower in the elderly than in middle-aged subjects, although the absolute risk compared to non-diabetics is higher. This is not actually a surprise. The real issue one needs to think about is, do you want to base your therapy based on relative risks and absolute risks? And usually the impact in general medicine has been doing more absolute risks or number needed to treat. Now, one other caveat, which is probably not so important in the elderly, is that these groups of diabetics with a prior MI have much higher event rates than non-diabetics with an MI, and everybody sees that. And that's partially the basis of even more aggressive lipid lowering, although I frankly don't think that has much of a role in treatment of elderly subjects, because there's absolutely no data in elderly subjects. All of the data that's been driven for even more aggressive therapy is all in middle-aged subjects. And in fact, the statin trials, if anything, are less impressive in the elderly than in middle age, probably because they have higher risk for other reasons. And there are a number of studies like Prosper. If people have questions, I'd be happy to talk about. Okay, so we're going to think about diabetics in general as having a threefold, fourfold, somewhere in that range increased risk, and we'll comment and talk about the metabolic syndrome a little later. The other issue that's clearly relevant for divisions which are at least partially hospital-based is looking at the problem of diabetes from the CHD backwards, the sort of way cardiologists look at it, in a case control methodology, which is looking at people who come in with a myocardial infarction. If you exclude people who are known to be diabetic, what proportion of these individuals have abnormal glucose tolerance if you do oral glucose tolerances? And it turns out that the data at discharge from this study from the Karolinska is shown in the bluish green bars, and it's 35% in IGT and it's 31% in new diabetes. So about 2/3 of people who have MIs but are non-diabetic have some form of oral abnormal glucose tolerance. If you repeat glucose tolerance tests 3 months later, you have about the same numbers. Now, if you were going to do VA-focused grants, thinking about interventions, this is actually interesting, because one of the things that's not been done along the diabetes prevention strategies is taking people post-MI. There are a lot of IGTs, and intervening either with a behavior program, which could be done by extending cardiac rehab, or drug interventions. Very high risk group. You may show effects on CHD as well. Could in an elderly group, this could be something that you could probably sell as potentially cost savings. It's something to at least think about. And if people are interested, we can talk about how you might design it. The advantage of doing post-MI interventions is that the absolute event rate is very high in the first year. So it might be actually feasible. Plus, many of the hospitals, and this is a good example, have lots and lots of MIs. So it could be done not in a single center, but it could certainly be done in a visit. Okay.
You know, it's interesting, we don't have a very high number of MRIs here, actually.
Really?
And it has nothing to do with our patient population. It has to do with the fact that
It's the referral patterns.
it's when you get in an ambulance, they take you to the nearest place.
You know, you could try testing it. There are other ways to do this that have not been done. But one of the things you might think about is people who get referred in for caths. That has not actually been done. But to figure out what the sampling fraction is with glucose tolerance testing. And then if it was close to being as high, then you could design a study around stable or unstable caths. But I think it's a powerful model, and it's the sort of thing that treatment effects have been fairly high for. In theory, it could be cost savings. You know, event rates are high. Okay, let's skip that. Skip that. Let's skip through. I think I should. I've talked about this. Okay. So I'm going to talk a little bit about information here. The case for CRP and its linked to theories about the metabolic syndrome principally comes from observational data, mainly from Paul Ritger at the Brigham. So this is from the Women's Health Initiative, and San Antonio was a center in the Women's Health Initiative. Powerstein initially was the PI, and now, God, I haven't seen him. Bob Schenken is now taken over. And so this is some data from this, and it's actually very interesting because it in a way explains both the positive and negative data in the concept for a C-reactive protein. So the way Ritger set this up was pretty clever. He looked at, hi Bob, he looked at Framingham global risk across the bottom. These are global risk scores. And within each of these 4 categories, he looked at cuts of CRP, which roughly correspond to the AHA CDC recommendations, which came out in circulation in January of 2003. And what Paul Ritger generally has emphasized is that within every strata of Framingham global risk score, higher CRPs predict future risk of cardiovascular disease. And cardiologists have looked at stuff like this. Whenever you see stuff like that, it's almost too good to be true. You know, there's no inconsistencies in the data. And a lot of people have interpreted you really need to measure this in everybody, and if you have a CRP, a high CRP, you're automatically at high risk and you know have to intervene. The problem, of course, is that this is an extraordinarily low risk population. And of course this was used by Wyeth Ayers when they attacked the concept of postmenopausal hormones aren't so bad, they were low risk, there was a low attributable risk and so on. But they were very low risk, so they attacked it for the wrong reason. On average, in the Women's Health Initiative, only 2% of the women develop CHD over a 10-year period. So that's far lower than the NCEP criteria for general, even moderate lipid level. So if we go back and look at this, you see these women they have a 0 to 1% risk over 10 years. They're really, really low. So these women have 3 times the risk, but these women with a very, very low global risk and a high CRP actually have lower risk than women who have a 2 to 4% global risk over 10 years, who are still low with a very low CRP. And this is behind the recommendations only to look at them as intermediate risk. So I asked you the question, why does this curve look so impressive? Does anybody figure out the sleight of hand that got this paper into the New England Journal rather than the AJE? That the reviewers didn't understand, nor the editors? I spoke to both of the reviewers. What's the y-axis?
Relative risk.
What should have been in this curve?
Absolutely.
Okay. So let's figure out what the absolute risks probably are. If the estimated risk corresponds to the actual risk, which it does in this study, this group on average is 0 to 1%. This group then, at the bottom, probably is 0 to 3% to 0 to 5% over 10 years. That top group up there that has a 25% increase, which everybody thinks is absolute risk, is 25 times, to be charitable, 0.5%, which is probably an overestimate. That's only 12.5%. So in the future, if you want to get papers in the New England Journal, you can do what the Brigham groups traditionally do, is look at relative risk and define the low risk group is vanishingly low. Anybody remember what the hazard ratios are for obesity at the top for developing diabetes at the Nurses' Health Study? They're 90. We were very impressed. We never get that in the San Antonio Heart Study. How do they do that? Well, one is they don't actually measure diabetes. They deal with self-report. And 2 is they don't deal with social class, since everybody's a nurse, whether they're married to a surgeon or they're unemployed single mother. They don't collect information on education, nor on income, nor on occupation. Very interesting. Social class isn't important, according to the Nurses' Health Study. But most interesting of all, the referent population, people who have BMIs of less than 18.5.
Oh.
How many patients in the United States have BMIs of less than 18.5? Very, very few. They had about 10 people in it, none of whom developed diabetes. And that's how you get hazard ratios of 90. So this is just sort of a little bit of an creative data display, I guess is one way to describe it, somewhat charitable. Anyway, so this data both supports the concept of measuring it and undercuts the concept of measuring it, particularly in low-risk groups. Now, it's actually a much better at predicting diabetes than it is at predicting heart disease, which is probably not such a surprise. So this is work from a former postdoc of ours, Andres Fester, who's now back in Austria. And this is based on IRIS cross-sectional study, which was a study that we did and tortured nurses on the CRC for many, many years. Still torture people in radiology with it. Looking at metabolic syndrome, it's not actually NSEP, it's more like the WHO definition. You can see it's both related to insulin resistance and to the number of metabolic disorders. This is looking at the development of diabetes. Now, so in our analysis, we estimate that these risks, which show a 3-fold increase from quartile 4 to quartile 1. Most people say this is less impressive than the Women's Health Study Initiative. How did they calculate? Well, they calculated by using a logistic regression analysis, estimating it the 90th to 10th percentile. They just estimated it at more extreme values. It doesn't actually give you the shape of the relationship, because that's hidden in a sense. But anyway, it is a pretty good predictor. Pi 1's even better, but nobody measures Pi 1 because it has to be collected in citrated tubes and chilled immediately. And fibrinogen, that actually analysis isn't really optimal because we used a simple chi-square. It should have been tested by a trend, and actually if you test it by a trend, it's barely significant, but it's not very strong. Okay. This is actually sort of interesting. So this is a follow-up, in a sense, that came out in CERC about 1.5 years ago, looking at pre-diabetic subjects. And what we can do in the IRIS is we did frequently sampled intravenous glucose tolerance tests, and we developed a measure of insulin resistance from the minimal model of SI. And the way we defined this is among non-diabetics, we took people below the median. Very conservative measure of what insulin resistance is. And we also had a measure for insulin secretory effort. And what we did is what's called an acute insulin response. A frequently sampled intravenous glucose tolerance test gives glucose at time 0 and gives insulin at 20 minutes. It's a standard sort of procedure. And the acute insulin response is first phase insulin secretion from 2 to 4 minutes. And then we could divide diabetic subject or pre-diabetic subjects into whether they have both insulin resistance and low insulin secretion. That's a little bit over half people, whether they're just insulin resistant, whether they just have a secretory defect, or they have neither. Very few people. We can't identify a defect. And it turns out if you look at the CRP levels, these two groups are pre-diabetics, but this group is an insulin resistant pre-diabetic, and this is a group of people with just a secretory defect. The only people who have high CRPs are those who are insulin resistant pre-diabetics. And these glucose levels are very, very similar. And so what that suggests is what characterizes high levels of inflammation in the pre-diabetic state, in spite of people have mixed defects, is really their insulin resistance. Now, the problem in this analysis is these pre-diabetics who are insulin resistant are fatter. So is it the fatness or is it the insulin resistance? So what we did then is we stratified the data again. And now we stratified by a median BMI, which was about 28. The same with waist circumference. And we got something that was very interesting. What we got is that the insulin-resistant pre-diabetics had the same high CRPs, regardless of whether they were leaner or fatter. The pre-diabetics who just had a secretory defect had the same low CRPs, regardless of whether they were lean or fat. What this suggests is fat people have high levels of inflammation, but it's because they're insulin resistant, not because they're obesity per se. Now, it's still important because if you look at the unconstrained people who don't develop diabetes, in the white bars the levels are twice as high. And if you look at the data we published in Diabetes in May from the Diabetes Prevention Project, if you get people to lose weight over 1 year, about a 7% weight loss, you drop your CRPs by about 27%, which is, which is the same as you get with TZDs. So what I'm going to do is I'm going to talk a little bit about the metabolic syndrome model. And I'm going to focus mainly here on the risk of CHD and whether all of these components are equally important. And then I'm going to make some references to sort of a new definition out there. What people obviously need is a new definition, of course. The old ones weren't adequate. And then talk about how it's going to be sort of pushed. So this is something that came out from Scott Grundy, and it sort of looked at CHD interventions. And so for many, many years, the model of the NCEP is that high LDLs cause coronary heart disease. And they were very, very monotheistic in terms of looking at a single type of intervention. And actually, it's been a pretty successful group. And so in the 2001 recommendations, they suggested that there were parallel or initial mechanisms for coronary heart disease and also for diabetes. And the problem is that there are a whole bunch of definitions. And why are there a whole bunch of definitions? Well, some of it you could probably guess. Different people have developed different definitions, and there's ego involved. Of course, true scientists never have any ego involved, but you know, it's possible. Unlikely that it might be. But there are also different concepts that underlie it. And as far as I can tell, there are at least 3 concepts underlying it, and they don't have to be mutually exclusive. So, one is the environmental causes are responsible for the epidemic of the metabolic syndrome. And this is the view of the NCEP, and it's actually sort of the view of the IDF as well, which I'm going to talk about in a minute, International Diabetes Federation. And if you believe this sort of thing, you would target your interventions to behavioral interventions, weight loss and increased physical activity. The second view is that insulin resistance is the underlying cause of the metabolic syndrome. And this was the position of the World Health Organization. This was the viewpoint for Jerry Reven. And if you believe this, you could do behavioral interventions, but you also could give pharmacological therapy to non-diabetic subjects with insulin sensitizers. And the third view is maybe this is all an inflammatory factor. And then you have even more interventions, because you might have behavior, you might have insulin sensitizing interventions, but you also might give other things that lower CRP, like statins or ACE inhibitors or ARB. So it's even more pharma-friendly. Okay, so this is the NCEP definition. It's any 3 out of 5 factors. I'm sure you all know it. You should be even becoming more postprandial and falling asleep at this point. Now, I alluded to the fact that there was an International Diabetes Federation definition. And this was sort of, came out of the closet. I don't know if that's a good or bad term, but in some ways apt, in a meeting in Berlin in April. And it's available at the IDF website. Now, the important thing probably, and it's actually going to be published in the Lancet in September, just another good indication of how far the Lancet has fallen in terms of its quality of papers. But the important thing for clinical purposes to remember is that it's very, very, very similar to the NCEP. In fact, it was a capitulation to the NCEP. The same cast of criminals who developed the WHO definition, Paul Zimmet and George Alberti, were moving forces in the idea. But there are 2 differences. One is they've made a high waist circumference a required component of the metabolic syndrome. It's no longer any 3 out of 5. In other words, if you don't have a high waist circumference, even if you have glucose intolerance and you're hypertensive and you have a high triglyceride and a low HDL, you can't have the metabolic syndrome. It's sort of more ideological. The second, which probably wasn't such a bad idea, is they lowered the cut points for some ethnic groups below 102 and 88. So the one that clearly made the most sense were in South Asians. They lowered it to 90 centimeters in men and 80 centimeters in women, and you know, that makes sense because South Asians, people of Indian or Pakistani or Bangladeshi descent, seem to have more visceral fat and metabolic variables at the same waist circumference. But they also have some really weird things that in there. So there's data from Japan by Matazawa, who's very, very prominent diabetologist, who really first used CAT scans for visceral fat and developed the first assays for adiponectin. According to some data from Japan, they have a higher cut point for waist circumference, a lower cut point, a higher cut point for waist circumference in women than men. It's the opposite in all different groups. So how does this happen? Why would it be different in Japanese subjects than Chinese subjects or South Asian or Caucasians? Well, it turns out they used a different way to develop their cut point. So in most populations, what they did is they looked at outcome variables and they said, what was the waist circumference where we thought the increases in coronary heart disease and diabetes occurred? And it turns out that women started developing higher risk at lower waist circumferences. So what did Matazawa do? Well, Matazawa decided that the important amount of visceral fat was at about 100 cubic inches. Usually in Western societies, people think it's 150. That's not actually a problem. But then what Matazawa did is he said, what waist circumference corresponds to 100 cubic inches? Since women have more subcutaneous fat than men, this meant that women had to have a higher waist circumference to have the proper amount of visceral fat to have more complications. So he used an assessment tool which worked in the opposite direction than all the other studies. Is that clear? So it led to a very, very funny recommendation. In fact, most people, when they looked at the website, thought it was a typo. It was supposed to be the opposite, that Japanese men was supposed to be at 90 and Japanese women were supposed to be at 85, but it wasn't a typo. It's Japanese women are at 90 and Japanese men are at 85. Very weird. That happens when you get lots of experts together. So you all know what talking heads are. People watch Sunday morning talk shows. What's a talking head? Somebody who's never in doubt but often wrong. So a summary of consensus companies. Okay, so we're going to talk now about 3 studies on the metabolic syndrome. One of those studies is a paper by Lacker. It is based on the Copio Heart study, about 1,100 men, followed for about 10 years on average, and looking at cardiovascular mortality. And in this study, the relative risk associated with the metabolic syndrome was about 3.6. Pretty high. This is higher than diabetes in the Framingham study is for cardiovascular disease. So if this study is representative, this might suggest that all people with the metabolic syndrome might be treated as if they sort of had CHD. Study in Northern Europe, and we're going to come back to it. The next study also has its problems. This is cross-sectional data. It's based on data from N. Haynes. There were 2 things basically that came out of this paper. One is that 85% of subjects with type 2 diabetes had the metabolic syndrome. So not everybody, but almost everybody. And the other is, if you look to the left of it, people with the metabolic syndrome but without diabetes had about a 60% higher risk or prevalence of CHD than people without diabetes or the metabolic syndrome. So this is less like a CHD risk equivalent and sort of more like a major risk factor like hypertension or diabetes. I'm going to show you one more paper, which actually is a paper from Kelly Hunt, who's in our group in San Antonio, based on the San Antonio Heart Study, published in Circulation last September. Now, here we're again looking at cardiovascular mortality. This is now 13-year mortality. It's about 2.5 times as many subjects as the Copio Heart Study. And we stratified people separately by gender and also separately by diabetes and the metabolic syndrome. And when we did that, individuals without diabetes or the metabolic syndrome had the lowest degree of risk. That's sort of a no-brainer. Individuals with just the metabolic syndrome, the second row, the increased risk was about 2.1 in women and about 2 in men. And that's, again, a moderate increased risk, more like a CHD risk factor than a CHD risk equivalent. Note that the relative risk is very similar in women and men in this case if you don't have diabetes. What about the relatively rare cases of people who have diabetes but don't have the metabolic syndrome? About 15% of the population. There the risk is about 3.5 in women and 2.3 in men. So you kind of start to see greater risk in women than in men. But these individuals are pretty atypical. What about individuals who have both diabetes and the metabolic syndrome? Here the risk more than doubles in women. It goes from 3.5 to 8.2, where it increases only a moderate degree in men. So what this study appears to suggest is there's a moderate increase in non-diabetics, not much different in men and women. The metabolic syndrome has a particularly pernicious effect in diabetics, particularly in women, but even on its own, diabetes without the metabolic syndrome has a risk at least as high as the metabolic syndrome.
What kind of absolute risk do you see?
Good question. So in the fourth group of individuals, people with both diabetes and the metabolic syndrome, they're the group where the absolute risk of cardiovascular disease, mortality, is the same in men and women. So part of the reason why some studies may have disagreed on whether diabetes fully eliminates the excess risk of CHD in men may be because there were different proportions of people with the metabolic syndrome and without. And in the people with just diabetes, there's still a preponderance for men having more cardiovascular mortality. So this might be useful, and it also might be useful in evaluating things for lipid therapy. It may be that people who have diabetes but have high HDLs and low triglycerides and low blood pressures and so on, their risk isn't so high. You know, maybe you don't have to treat all of them incredibly aggressively. But that's something you might have predicted, since we know that conventional risk factors are important. Okay. So this slide talks about components of the metabolic syndrome. And it asks whether all components of the metabolic syndrome are equally important for CHD. And in this case, the significant independent predictors of CHD are low HDLs, high blood pressures, and diabetes. High waist circumference, high triglycerides, impaired fasting glucose is less important, which is kind of interesting. How can this be helpful in explaining different risks of the metabolic syndrome across populations? Well, if you look at what characterizes the metabolic syndrome in North America, it's that almost everybody is obese. And obesity by itself is not such a strong independent risk factor for the metabolic syndrome. If you look at what characterizes people with the metabolic syndrome in Northern Europe, it's that they're all hypertensive. And hypertensive subjects almost always have greatly increased risk of CHD and stroke. So what this suggests is, even with the same definitions of the metabolic syndrome, the risk of CHD may differ widely depending upon which components people have. And this is part of the attacks people have on the metabolic syndrome, that it's not a homogeneous disease. There are different risk factors. And in a sense, it gets even worse. So if we look at data, and this is from Carlos Lorenzo, who works in our group, based on the San Antonio Heart Study published in Diabetes Care a year and a half ago. In this case, we stratified people by both impaired glucose tolerance and not, and people having the metabolic syndrome and not. And you can see IGT is a more important risk factor than is the metabolic syndrome, but the metabolic syndrome contributes to risk both in people without the with normal glucose tolerance and impaired glucose tolerance. And this, in fact, is useful in thinking about interventions for prevention. In the Diabetes Prevention Project, we showed about a 58% reduction in the risk of type 2 diabetes with about a 5% average weight loss. It's a very steep curve. So this suggests that the primary therapy should always be behavioral. But are there people who need more than behavior? So let's work through some of the numbers. So if we look at people who have IGT but don't have the metabolic syndrome, and this is data over 7 years, their risk of developing type 2 diabetes is about 25%, or 3.5% per year. If you cut that in half with behavior, it's a little less than 2% per year. That's probably okay, just using behavior. But if you take people with IGT and the metabolic syndrome, their risk over 7 years is about 55%. And even if you cut that in half with behavior, it's 25 to 30%. And that may be unacceptable. And so the highest risk subjects might need more aggressive therapy, which can be a combination of behavior and pharmacological therapy. Now, there are a couple of caveats here. One is, nobody to date has done a factorial design behavioral intervention with drug. We know this from separate interventions, so that's sort of a leap of faith. But if you believe in this sort of approach, which is roughly analogous to the NCEP approach, which is sort of grading the intensity of therapy according to the degree of risk. And that makes sense to a lot of people. I should point out, however, for most chronic diseases, that's not what we do. Look at diabetes. In diabetes, there's a goal of less than 7%. The goal is the same if people are hypertensive or not, which increases risk of disease. It's the same in people who develop their diabetes at 15 or 20, who might be expected to have 60 years of high hemoglobin A1Cs, for which you might really want to reduce the hemoglobin A1C to normal, 5.5, as it is for people who develop type 2 diabetes at the age of 85, for which we've done no clinical trials and are unlikely to develop significant microvascular complications during their life cycle. So the NCEP model, which I'm proposing could be used for prevention, actually is atypical. Hypertension is another good example. JNC7 has more aggressive goals for diabetic subjects than for kidney disease subjects. But do they have more aggressive goals for people with strokes or CHD? They actually did in JNC6, and they got rid of it in JNC7. They sort of moved away from this tiered approach. The Europeans, in their hypertension recommendations, do have a tiered approach depending upon risk. And it might be useful, particularly for fellows and stuff like that, to think about why some chronic diseases have a tiered approach and others do not. It shouldn't really differ. Okay, and I'm going to kind of end, skip that, by talking a little bit about non-alcoholic fatty liver disease. Almost all of this data has been generated, read the geriatrics literature, I confess, in middle-aged subjects. So this is an area you might think about. And it's about 5 or 6 years old now. The key paper came out in Diabetes in 2001 that was cross-sectional, that first pointed out that the prevalence of obesity and metabolic syndrome was correlated with non-alcoholic fatty liver disease and NASH. There then were smaller drug studies suggesting that the use of insulin sensitizers improved liver function test and reduced liver fat by ultrasound. And that was true with both metformin and TZDs. Then there was data from HEMA Indians that suggested that ALTs predicted type 2 diabetes. And that was actually the
Steve,
only...
I don't know the difference between fatty liver disease and NASH.
Okay. So non-alcoholic fatty liver disease or fat deposition in the liver, which can be identified by ALTs. NASH is steatosis. So there's fibrosis in the liver and it's more advanced. Most of the literature now appearing has been looking at elevated liver function tests as an indicator of people with non-alcoholic fatty liver disease. It is believed that non-alcoholic fatty liver disease is the most common cause in North America of people with elevated liver function tests who are not significant drinkers. So the data I'm going to talk about in the IRIS study looks both at the overall population and also excluding moderate to severe drinkers, which we defined as 2 or more drinks per day. Now that of course is in the eye of the beholder, what moderate and severe drinkers. We also exclude former drinkers, and we exclude former drinkers because we suspect that some of these people may have quit drinking because they had more disease before. But it turns out that it doesn't make much difference in our data, regardless of what we do. About a quarter of the subjects would be classified as moderate or severe drinkers or former drinkers. We don't lose that much power. So, this is from a paper that was published by Tony Hanley, who also has worked with us periodically, who's now at the University of Toronto, looking at ALTs. And so I'm going to just show you, I think, just one figure here. It might be 2, actually. The overall data suggests that ALTs predict risk of type 2 diabetes in IRIS. And then we look at a variety of subgroups, and there's no real evidence of heterogeneity, whether we look by gender or ethnic group or obesity or glucose tolerance. Now, more recent, and this looks at another issue, since this looks at the issue is the increased liver function test predicting diabetes due to the fact that people with elevated liver function tests at baseline may have impaired glucose tolerance or insulin resistance, have secretory defects. So this is a statistical issue about independent predictors. So model A is a demographic model, and model B is what statisticians would call a saturated model. It's a pretty good model because we actually have direct measures of insulin resistance and glucose tolerance. And you see, it doesn't make any difference, basically. We also use 2 different modeling approaches. One is using continuous variables, and we use the common log for the standard deviation of the distribution. The second is looking at the uppermost quartile versus the first 3 quartiles, so it's a categorical approach. In the paper we show all 4 quartiles as well. And I should tell you that people in the upper quartile are mainly in the normal range. Very few of them are actually outside the normal range. And that produces bigger odds ratios, which is not such a surprise, but not necessarily better fits. Okay, so the next question you could ask, is this due to high CRP? Remember I told you that CRP is a predictor of type 2 diabetes. CRP is produced in the liver. Maybe this is all a CRP phenomenon. So the first thing we did is we looked at how strong are ASTs and ALTs relative to CRP using a similar modeling strategy. And the answer is they were pretty much equally strong. And the other issue is they were independent of each other. So this literature on non-alcoholic fatty liver disease was not because the liver was associated being subjected to more inflammation, which was interesting. We were the first people who actually looked at that. Now, so we have another paper which is in press in diabetes, now looking at the incidence of the NSEP metabolic syndrome. And again, we can show that ALT, now we're showing quartile analysis, is associated with the development of the metabolic syndrome. Some people use the ALT to AST ratio, and we can show that's also associated, though it's inverse. And again, the ALTs and the CRPs are approximately the same strength. So why don't I end at this point, since it's actually after 1. I'm going to take some questions.
I'm assuming you have ALT and AST because that's what's available.
That's what our brilliant CRC did when we, as well as the other clinics.
You had GGT?
No, we don't have GGT. We have bilirubins, which are totally useless. We have alkaline phosphatases, which are actually interesting. We have total proteins, which are not very informative. Now, we have creatinines. We haven't actually worked that up. It actually occurred to me, when people came in on the CRC, they got smacks. So we didn't do that for all the centers. We do have follow-up data for San Antonio. We could probably pull that out of
If
our
you wanted
charts.
to, you could get a GGT by just ordering it in addition to the snacks.
Well, I'm thinking about data we've already collected, because this data set hasn't been funded in 7 years. But if we still have the records, they must have had the creatinines for their follow-up visits, which we can go back and look at. There's a lot of interest in mild degrees of renal insufficiency and the metabolic syndrome, and that's something we haven't actually done, and insulin resistance as well. And since we repeated FSIGTs, we can look at changes in insulin resistance and creatinines as well as ALT data, which hasn't actually been done in the study.
Do you have the data, or are the data available on gender differences in fatty liver or sex steroid?
Well, I showed you a little bit of data on the development of diabetes by gender. And the story for non-alcoholic fatty liver disease did not differ in terms of development of diabetes. And I didn't show you the data, but that was also true for the development of the metabolic syndrome. We do have data on all 1,600 people who have sex hormones. You're welcome to use the data. We've never done anything with it. We have all this data. We need more postdocs. What?
We've done it before.
You know, we did it with, remember, Dunn.
Yeah.
We never did, we sort of ran out of steam. So postdocs, we've got lots of data. We're down with the old IRIS. We're no longer funded. In fact, the statistical analysis comes out of slush money that we did drug studies with. So we're down to about 4 to 5 papers per year, though we've been doing really well. Our last 7 papers that have sort of come from our section have all been published in Diabetes and Circ. So we've done well. We just don't have as many of them.
What do you think? I mean, you say that all these data come from middle-aged people, essentially. Is there any? What do you think about these relationships with people who are of advanced age? And by advanced, I really mean, and I think there's, my problem with a lot of the JCN recommendations and NSEF recommendations are that they don't have any upper age limits for the most part. So,
Yeah, so the clinical trial data for lipids for people who don't have pre-existing vascular disease, most people accept that if you had a stroke or an MI, even if you're elderly, you should be treated.
Right.
I think that's true. But the only study that didn't look at people like that was Prosper with Pravastatin 40. It was a very unimpressive study. They had about a 15% treatment effect. I don't know what to make of it. You know?
well, I mean, I think even in my own thinking, I think there's something very different about people who are, say, 75 to 80, 70 to 80 or 85, and then people who are 85 and older. And
There's absolutely no data in the very, I mean, really no data.
well, there is some data. I mean, there's this. The only data that's available, say, for hypertension is that Swedish treatment of hypertension in the very elderly.
Right.
And the pilot study, when they did aggressive management of hypertension, showed that they did have about a 50% reduction in stroke risk, but they had an overall increase by 14% in mortality. And
I don't know how to interpret that sort of data.
well, it's interesting. I mean, I think it's just interesting that on balance, more people in the treatment group died.
But if you look at the TNT data, which was published in the New England Journal John Morosa in April, they had with very aggressive lipid lowering with a 2 over 80, they had a 22% reduction in their primary. And there was no difference in overall mortality. Actually, the non-cardiovascular mortality was increased by 25%. And that was almost statistically significant. It was 0.07. Part of what I think is happening is once you start getting people on active therapy, additional therapy looks a lot less impressive. Now, the Swedish very elderly study, was that placebo-controlled?
You know,
Or was it 2 different levels of blood pressure intensity?
but the SHEP study, the median,
The SHEP
study
was
young
placebo-controlled.
people, young or old people. And it was really, they had a very low median age. The median
Yeah.
age was under 70. And
Yeah, it was. Yeah, I reviewed a number of the SHEP papers.
Right, and not only that, their entry blood pressures were low. So,
I guess one way to look at it is you get to people who are 85. To a large degree, they're survivors. You have a different distribution.
yeah, they're different people.
And they may be relatively resistant to conventional risk factors. And the other issue is, frankly, in terms of quality of life, you know, it's hard to make asymptomatic people feel better. And if you're 50 years old and you have an LDL of 200, that's defendable.
Right.
But if you're 85 years old with an LDL of 200, we're not as smart as we appear. There may be other protective effects. Now, how do you get around this? Well, you could hedge your bets. You can treat people with low doses of therapy and generics, so it reduces their cost. These are reasonably well-tolerated drugs. Perish the thought you could treat very elderly subjects with ARBs. Of course, they're expensive, but they are very well tolerated. You really run into trouble on their own. They don't lower blood pressure very much. That's why ARBs are not very good in big clinical trials. But if what you're trying to do is shift the distribution a little bit, that might actually make sense. So if I was designing a VA study for the elderly, very elderly, that's the sort of intervention I would do. I would use low-dose generic statins in people without disease. You know, I don't think the Framingham risk scores mean anything in 80 or 85 because there weren't anybody at 80 or 85.
Right.
And I would think about a moderate blood pressure reduction, and I'd use ARBs, not because there's a better evidence base. It's worse, but because they're very, very well tolerated. And I would probably base the endpoint on quality of life and hospitalizations and not on mortality.
Yeah,
I mean,
it's confusing. I mean, I think it's confusing to know what to do. I think I don't have any difficulty with people who are sort of up to age 80, but after you reach age 80, it becomes very difficult to know what the goals are for anything.
Well, you have to define different goals.
Right, exactly. And the
And
problem
you have
is
to
that,
do therapy. You really have to do therapies that don't make people sick.
right, and I just wish
It's like
from
limiting
a
egg
geriatrician's
consumption in
perspective.
85 years.
Well, for instance, Steve, this year there's going to be authorizing legislation that's going to say that people are going to pay physicians for their performance and specific quality criteria, and maybe not pay them for non-performance in those areas. But what's happening is all these things are being promulgated. They're going to apply to the very elderly as well as to younger people. So you're going to see these people who are, they're going to have an LDL under 100 until they're 99. And I just think, I wish the national panels that do this would not go where the evidence isn't. Because a lot of the cholesterol stuff and the hypertension stuff, there is no evidence for some of the things they're proposing. And it's infuriating.
I'll tell you a little bit since I sat on the board the last time as a consultant. Part of the problems with making recommendations is that there's a conflict between precision and simplicity. And for a physician education or education in general, as a public health issue, simplicity is usually more important than precision. So I talked a little bit about diabetes as a CHD risk equivalent, and I talked a little bit where it might be a super equivalent as opposed to less than equivalent. But if you're going to go out in primary care, the way to educate people about treating lipids and diabetes is not to tell people to calculate risk scores, but in general tell people to treat them. I have a plenary talk at the European diabetes meetings on should all diabetics be on statins, which I'm going to try to sell to circulation as a commentary. And the answer is no, but you need a really pretty good reason not to.